General practice leaders are calling for an immediate boost to bulk billing incentives and patient rebates following a crisis summit to revitalise the sector. Joining us live is the Chair of the Royal Australia College of General Practitioners, New South Wales and ACT branch, Dr. Charlotte Hespe. Appreciate your time, Doctor. Thanks so much for your time. What stood out to you at this summit of GPs? What was the big takeaway?
I think it was fabulous having stakeholders from across Australia all join together in talking about what measures do we need to institute both immediately and short, long and long-term measures. And as you said, the immediate thing is about the absolute need, resounding support around the room to do something immediately to the Medicare rebates in some way to protect our vulnerable populations, particularly in rural, remote areas, to prevent practices having to close down. And that is around ensuring that patients have a better rebate, but more to the point that we do have an incentive to do bulk billing for patients who really cannot afford to access care at this time.
Yeah, a lot of the proposals did seem to really, when you break it down, come down to the point that you need more funding, that there needs to be more government funding in a range of areas to support GPs. Is that right? Does it just come down to more money, or are there other frameworks that can change that would make a real difference?
Look, I think there's a number of things. If you actually go down to what we're looking for as the long-term outcome, is that we actually have a government that is brave to actually really review our healthcare system as a whole and be able to redesign it so that we actually have a healthcare system that is designed to deliver health to people who are healthy and prevent things going wrong. At the moment, our system is actually what we would call a sick care system. So it's designed to cope for people who are already unwell. It was designed in the 70s when that was actually what was the most important thing, accessing people who were sick. Now we actually have a far more complex environment where we've got lots of people with chronic diseases and we want to prevent those chronic diseases. So we need to be able to keep people out of hospital. We need a health wellness type system. And that needs probably one funder rather than a mixture, which is what we currently face. And because it's really difficult, the states fund the hospitals, the federal government funds Medicare, which is where general practitioners sit. And because of that, there's sort of this really difficult ability to bring the two together. And COVID was fantastic in actually really seeing that the states need to also be working really in terms of that mixed funding with GPs as well. So one funder and a system that actually promotes wellness rather than sickness.
At least there was a silver lining then from COVID. I know that it caused real problems for GPs in a range of other areas. One is doctor burnout, as I understand it, that GPs have been reducing hours, some of them, or leaving altogether after those levels of burnout reached peak during the pandemic. Anecdotally, it does seem like it's harder to get in to see a GP. We know there's a skills shortage on at the moment, but what do you see as the outlook for the future? It seems to be a real problem that med students aren't broadly opting to make general practice their specialty.
Yeah, as you said, so going back to that first question you said, when is it just about funding? So look, we're really in a true crisis. Funding is going to be part of it. System redesign is a really big part of that. And then there's that whole thing, as you say, about how do we attract the future workforce, which is our medical students, into a system. At the moment they look at it and go, well, why would I want to go into part of the medical workforce that is really poorly remunerated and burnt out and unsupported under the current systems. So, you know, we've sort of got to re-educate, because general practice, from as far as I'm concerned, is the absolute best possible specialty you can train in. I love the holistic approach. I love looking after people from, you know, before birth right through to death, family care. The sort of the generalism is just fantastic. And yet at the moment we don't have a medical training system that actually is able to encourage that either. And there's a real culture of saying, oh, rather than do that general approach and look after everything, I just want to just look after the back of the eye. I want to look after the shoulder or the lungs or that part of the lungs. And we're getting more and more super specialised, which means we've actually got far too many specialist partialists, you know, and very few generalists, which is fascinating. That sort of dropped off over the last 20 years. We need to go back to basics and really try and attract medical students to generalism as a whole, of which general practice is one of those things. So paediatrics suffers the same thing. To find a paediatrician who is a generalist is really difficult. Physicians, very difficult. I don't mind the physicians not having it because the GP covers that off, but you know that's a whole big body of work, and we can do that right from the beginning of when medical students come in, redesigning the way in which we teach, and then too when junior doctors go into the system when they're finished medical school. At the moment, you do 3 years in the hospital and there is no general practice experience at all. So we're really calling for general practice to become one of the absolutely essential rotation terms for all junior doctors in that first sort of 1 to 3 years post-graduation. Because we know when we used to do that, that the turnover then of doctors who'd actually been into general practice was much, much higher. You know, you do it and you realise the joy, so you're much more likely to come into it. We also need to look at the way in which we employ them. At the moment, there is no equity across the specialists. So for me, as a GP, if I move as a junior doctor from the hospital across into general practice, I drop my income, I lose annual leave, I lose maternity leave, I lose paternity leave, annual leave, etc. All employment entitlements go out the door. And so again, it's like, well, why would you want to do that? Because if you stay in the hospital system, you're higher pay and all of those leave entitlements.
Sounds like there's plenty of room for improvement. Just finally, Doctor, I imagine that COVID management was a bit of a water cooler topic over the summit among your GP colleagues. What was the mood generally about the current settings, the lack of an isolation requirement now?
Look, I think it's very difficult because a lot of patients don't understand that the medical sector still needs to maintain face masks and protection because we're not over COVID, we're now into this sort of living with COVID. And living with COVID means that we still have risk of infection around. And in fact, as we know, I mean, I'm just seeing so many quite nasty upper respiratory tract infections that are not COVID as well. And we didn't see any of that during COVID because people were wearing masks. So we need to continue to have masks, hand hygiene, think about social isolating when you're in the context of a hospital, aged care facility and in general practice to make sure that nobody is put at risk of getting an infection when they're actually within a healthcare setting. And that's really difficult. So many of my patients go, I just want to take this face mask off and I want to be sitting closer to you. And, you know, that's tricky. And also navigating, you know, when someone's acutely unwell, are they able to come into the surgery? And if they do, what are the measures that we do to try and make sure that other people around them aren't put at risk? Using telehealth appropriately. My patients, can I say, love video because it saves all of that travel time, waiting in the waiting room and potentially at risk of other things. And I call them when I'm ready to see them so they can get on with things so that wait time isn't so bothersome. So putting all of that into context, how we sort of change the way in which we deliver care, but as I said, understand that masks may well be the long-term part of actually accessing medical services.
Yep, sounds like masks are there to stay in those certain settings for the foreseeable future, no doubt about that. Dr. Charlotte Hespe, really appreciate you joining us. Thanks for your time.
Thank you very much.